So we know that the number of oocytes decreases with age. As I said, this decline is independent of ovulation. Quality of the oocytes decreases with advancing age. So you get increased mitotic spindle abnormalities and then increased aneuploid in preimplantation embryos. So not only do pregnancy rates decline, but unfortunately miscarriage rates and aneuploid does increase with time. The age is the primary predictor for pregnancy. So while we have these tests to tell us about the ovarian pool that's left, these are really surrogate markers for this. And we do know patients who have low egg reserve who may still conceive, and patients who have who have very high egg reserve who may not conceive. Again, we're looking at the age is the primary predictor, and that there really is no other good quality test. We do have lab tests like the day 3 FSH and estradiol. These are looking in the early follicular phase. They are most accurate, and that's day 2, 3, or 4. And you want to get both an FSH and an estradiol because you need the estradiol to evaluate your FSH. We also have a blood test, the anti-Müllerian hormone. This is cycle independent, and this is released by the granulosa cells of the follicles, kind of giving us a sense of the basket of eggs. Again, AMH does not predict whether or not someone will have a baby. Age does, but it may predict response to treatment. We can also do an ultrasound and do what's called an antral follicle count. Again, this is typically done early in the cycle in the follicular phase, and you're looking at those small follicles that are between 2 to 10 millimeters. And this looks another surrogate marker for the egg reserve. We can freeze mature eggs, we can freeze embryos, we can freeze ovarian tissue, and we can also perform in vitro maturation. So sperm, oocyte, and embryo freezing are the most likely strategies to yield for future pregnancies. And the discussion and referral should be made at the earliest opportunity to allow adequate time and options to complete more than one cycle. This requires a 2 to 3 week window for ovarian stimulation and oocyte retrieval for women freezing eggs or embryos. I think it's important for women to be educated about the natural decline in fertility and educated about their options so that they can make the best decision for themselves. On this chart, the x-axis is the age at which the woman decides to freeze or not freeze her eggs. On the y-axis, we present the subsequent probability of a live birth 7 years later. So the blue line shows the live birth rate by age among women who decide to freeze their eggs, and the red line is the live birth rate among women who do not freeze their eggs. So your highest live birth rates for women freezing eggs are observed between 25 and 30. But in this, if you look in this age group, the difference between natural fertility and pregnancy after assisted reproductive technologies is actually minimal. So suggesting that at this age, it may have minimal benefit if the eggs are used within 7 years, because then you could potentially just do your own IVF cycle, in that time frame, right? In the early 30s, the difference becomes greater. So at age 32, there was a 12.5% difference, in live birth rates between those who froze and those who didn't. But if you chose to freeze at 37, you had a 50% chance of having a live birth, whereas if you didn't, your chance would be 20%. So that may be a little high for that natural fecundity at that age, but it's just the bottom line is the early to mid 30s is probably best for yield and to decrease the risks for aneuploidy. Often we do put patients on some sort of pre-stimulation treatment like a birth control pill or Lupron. We may just start with their period. And again, with cancer patients, we do random starts for time sensitivity. But basically, they're taking 9 to 14 days of daily injections of FSH. And so what I tell patients is, remember, at the beginning of your cycle, you have a new cohort of eggs, of follicles. And in your natural cycle, one of those is chosen and the rest die. But in IVF, what we're doing is we're giving you higher doses of FSH, the same hormone that comes from your brain. And they're taking FSH injections daily for about 9 to 14 days. And then we also add a medication like a GnRH antagonist to prevent ovulation. So once we get a good cohort of mature follicles, then we trigger ovulation with either HCG or Lupron, which they both work on the LH receptor, and then schedule egg retrieval roughly 35 to 36 hours later. We usually use a transvaginal probe, which has a needle guide. Basically, you're just going directly, you just gently puncture the vaginal wall, and you can gently move around the ovary. We can do abdominal retrieval for patients who have cervical cancer masses, so we can do that as well, although the yield is not as good as in the vaginal, but it is possible. We obtain those eggs, we evaluate those eggs for maturity, and then they can either be cryopreserved right away at that point or inseminated with sperm to form embryos. If the fertilization is successful, then we monitor these embryos for 5 to 7 days in the lab. And then there is the option of the embryos for preimplantation genetic testing for genetic disorders.
We refer to testing of embryos as preimplantation genetic testing, and there are several flavors of that. PGT-M stands for preimplantation genetic testing for monogenic disorders. We have PGT-SR, which is testing for structural rearrangements, and then PGT-A, which is testing for aneuploidy. We have to start by doing in vitro fertilization, IVF. The eggs are combined with sperm in the laboratory, and the fertilized zygotes grow for several days until they reach the blastocyst stage of development, around days 5 or 6 of embryo development, at which point a trophectoderm biopsy is performed. Several cells, usually 5, 6, or 7 cells, are removed from the trophectoderm. And that's important that it's a trophectoderm biopsy because the inner cell mass is not affected. So there's potentially less damage to the future child. And it's also important in terms of interpretation. We're not sampling the entire embryo, but we're sampling just the trophectoderm. After the biopsy is performed, the embryos are usually cryopreserved, and the genetic analysis is performed on those biopsied cells. It is used for detecting single gene disorders. And this includes autosomal recessive or dominant or X-linked disorders. Initially, when the technique was first developed, it was applied to severe conditions with onset at birth or soon thereafter. However, since the inception, the applications have greatly increased, and we now can utilize PGT-M for severe adult onset conditions. Also, less serious or perhaps conditions with lower penetrance that are adult onset can also be tested for. Preconception, family history, and carrier screening becomes even more important when you understand the large usability of PGT-M. Because if we can identify individuals and couples at risk, we can prevent having offspring with that disease. Carrier screening can be done certainly at any time. The best time to do it is before pregnancy so that PGT-M can be offered. PGT-A allows for comprehensive chromosome screening of the embryos. The value indications for this remain controversial. We have to be cautious because our history has taught us that if applied prematurely, techniques may cause harm. We still have limited data regarding the usefulness of PGT-A and its safety, and hence the controversy continues. Why is PGT-A important at all? It reflects the problem of aneuploidy in our gametes and in embryos. We know that many of the embryos, in fact, most of the embryos produced, are aneuploid. At the age of 38, approximately 50% of blastocysts achieved are found to be aneuploid, and the percentage greatly increases with the individual's age after that. If an aneuploid embryo is transferred into a woman's uterus, most of the time a pregnancy will not result. If a pregnancy does result, the vast majority of those pregnancies will end up as a pregnancy lost, mostly early in the first trimester. And one of the main complexities of PGT-A is the concept of mosaicism. Mosaicism being the presence of more than one cell line within an embryo. And the most common scenario we think of where there may be aneuploid cells present both in the trophectoderm and in the inner cell mass. But there are different types of mosaicism where sometimes mosaicism may be exclusively found in the inner cell mass, whereas other times exclusively in the trophectoderm. Trophectoderm biopsies have been well correlated when the test results shows that the embryo is euploid or aneuploid. However, there's less concordance in the setting of mosaicism. Next generation sequencing allowed us to have a much higher detection rate of mosaicism. And the prevalence of mosaicism has been reported to be over a significantly differing range, where some techniques demonstrating as low as 3%, while others demonstrating over 20%. This has led some to speculate that perhaps mosaicism is being overcalled by some labs and maybe nothing more than noise or lab error. Perhaps it's due to the techniques used to perform the biopsy itself. Other theories include that mosaic embryos may self-correct and still result in normal birth. And you can imagine a scenario where, for example, the embryo here in the picture has several cells that are aneuploid. But the aneuploid cells are not as healthy, perhaps, as the euploid cells. And as the embryo continues to grow and divide, the aneuploid cell line may work itself out because their reproduction rate will be much less efficient, perhaps, than the healthier cells. So hence the theory of self-correction, where the embryo will continue to grow and divide if it has a substantial amount of healthy euploid cells, and the embryo may still be successful.